Welcome to another episode of Follow the Brand. I am your host, Grant Mauvar, CEO of 5-Star BDM, a 5-star personal branding and business development company. I want to take you on a journey that takes another deep dive into the world of personal branding and business development using compelling personal story, business conversations, and tips to improve your personal brand. By listening to the Follow the Brand podcast series, you will be able to differentiate yourself from the competition and allow you to build trust with prospective clients and employers. You never get a second chance to make a first impression. Make it one that will set you apart, build trust, and reflect who you are. Developing your 5-star personal brand is a great way to demonstrate your skills and knowledge. If you have any questions for me or my guests, please email me at grant.mauvar, spelled M-C-G-A-U-G-H, at 5-star BDM, B for brand, D for development, M for masters.com. Now let's begin with our next 5-star episode on Follow the Brand. Hello, and welcome to the Follow the Brand podcast. I am your host, Grant Mauvar, CEO of 5-Star BDM, where we help you to build a 5-star brand that people will follow. Have you heard the words non-compliant or not adherent in a clinical setting? Dr. Mauvareen Beverly has. She has developed a care management program to get to the root cause of this patient population to reduce hospital readmissions. Dr. Beverly says, we must treat the whole person and not just the patient. In the case of sickle cell patients who are the least addicted, yet the most vilified when it comes to empathetic care. She has a progressive training program that asks the question, why? To reveal the human values in a clinical care setting. Her cultural competency program targets patients that have been targeted as non-compliant and have reduced their readmission rates substantially. Her non-judgemental empathetic approach has proven to be a very effective method for improving patient outcomes. Dr. Mauvareen Beverly is an executive-level physician with 20 years of experience advocating for improving patient engagement and cultural competence for all populations, especially the geriatric, immigrant, and African American communities. As AVP, Physician Advisor for NYC Health and Hospitals, she sponsored the first conference on improving the health of the elderly Black population. She implemented the concept of the Bridge Team, whose role was to bridge the gap in care for the most complicated and vulnerable population, and as a result, improve care and health outcomes. As Deputy Executive Director of Kings County Hospital, her team decreased congestive heart failure for readmission from 30% to 18.7% in less than 2 years. Dr. Beverly is a fellow at the New York Academy of Medicine, and her abstract Health Disparities and Epidemics, which is called Perception versus Reality, was selected for presentation at NYAM during its 12th Annual History of Medicine and Public Health Night. Dr. Beverly is also a member of the American Medical Association and Medical Society, State of New York, working in collaboration with Westchester County Medical Society, Westchester Academy of Medicine, and Putnam County Medical Society in developing patient engagement and cultural competent training programs with CME credits. Dr. Beverly received her bachelor's from Boston University and MD from University of Buffalo School of Medicine. She completed her internship and residency in internal medicine at Harlem Hospital in New York Columbia Presbyterian. She is the president of Mauvareen Beverly MD PLLC, Patient Engagement and Cultural Competence Specialist. Let us welcome Dr. Beverly to the Follow the Brand podcast, where we are building a 5-star brand that you can follow. Welcome, everyone, to another great episode on the Follow the Brand podcast. Today, we're going to talk about culture, and we're going to talk about culture in medicine, specifically in the clinical field. We've got Dr. Beverly here with us today. She's very passionate. I've known her for a number of different years, and we met through the National Association of Health Services Executives, which has been wonderful. We've had a lot of ongoing conversations. She's one of my first clients, actually, at 5-Star BDM, and I really appreciated her, but it was her story that was so intriguing. So I'd like to bring her up. Let's just get an introduction going. So Dr. Beverly, how are you today?
I'm great. How are you?
I am wonderful because you're on the show, and we're going to talk about what you are most passionate about. Now, I know you've been a physician in New York City, for a long period of time where there's not a lot of people of color practicing medicine, and then you've made this pivot into training. Is that right?
And I think, Grant, when we ask each other, is any of your children physician? I think out of the 200, if there were 5, that was a lot.
Right.
So I think that had everybody, let's say, and people get to choose what they want to do. So I'm not making a judgment at all. But I think the gap in it is that if Harlem Hospital in New York is representative across the country, then the gap is the age group, our adult children, our adult individuals would be physicians today, and the gap would not be as wide. And that's just a personal opinion. And I would never have thought about that until we had the reunion and we were trying to connect, with everybody and try to figure out where's everybody, the children, how many kids, what do they do, and I just found that interesting.
I think it's very, very interesting. I hear about it all the time. I've seen, blackdoctors.org. They talk about, black men in white coats, things
right.
of that nature. And we talk about it at Meharry, they're always, we need more doctors, we need to recruit, we need to bring them in. So this is a big thing.
Yeah.
But I want to talk more about what you've been doing. Now, you have a passion, great passion for decreasing health disparities, particularly among the elderly Black populations and individuals with sickle cell disease. And I want to know, how did that passion come about?
Okay. So I think it was back in 2007. I was hired by Dr. Sullivan, who was in charge of Queens Health Network, which was in charge of Elmhurst and Queens Hospital, which is a part of New York City Health and Hospital. And she was forward thinking in the sense that she wanted to develop the care management program. And back then, care management was not, part of the conversation. And because I worked previously in community health centers, and was very familiar with the requirements for the community. And I also trained at Harlem Hospital, Columbia Presbyterian. So I think I had the knowledge and what she was looking for to help develop a program. And the interesting thing, she didn't give me any information. She said, it's up to you to develop the program. So I interviewed with the chief medical officers in both hospitals, the head of the emergency room, the head of nursing, you name it, head of social worker. And I came up with the concept of the care management program, the bridge team. And the idea of the bridge team, bridge the gap. Whatever the gap is, bridge the gap. And it's an opportunity for the team to have a little extra time to speak to patients and family to find out what's important to them. And how do we transfer that information to the clinical team and make it so that the transition of care and the care received in the hospital is really coordinated and the best interest of the patient. And so the bridge team, so in the team, it's made up of case managers, care managers, social workers, clerical associate in both hospitals, and the head of care management in both hospitals who reported to me. So we had to design the program. And what was interesting is that in Elmhurst is a large Asian Hispanic population, and then it was a growing Russian population. In Queens, it was a large African American population, and at that time, the second most popular group then was Guyanese. There were Indians from Guyana, and so it was interesting dynamic. You know, the difference in population couldn't be more diverse than that. So anyway, so the whole idea of the bridge team was, let's look at who are the most vulnerable populations and see how we could coordinate the care and help that family and the hospitals collaborate in a much more effective manner. And so I was told to see this 18-year-old in Elmhurst, in Queens. And she's forever embedded in my brain. So the team, the bridge, 9 o'clock in the morning, the bridge team goes, and we're about to enter her room. And she gave us the body language. I'm on my phone, So I said, okay, let's hold off. And, so the team is whispering. That's what they say. She's so disrespectful, she's so attitudinal. And I'm thinking, what 18-year-old is not attitudinal without a life-threatening disease? Why don't we just give her the benefit of the doubt? And so she got off the phone, and we were about to enter her room. And like I said, the statements, and that's what I think what I call stop in your tracks moment, because this is not what you anticipate when you develop a program that you think is really comprehensive. And Granchi said, if you have a cure, come in. If you don't, and she pointed her finger, keep walking.
Wow.
So did I? Oh my God. So then now interesting. So there, it even gets more interesting. So it's like I became the child and she became the adult, because guess what she said? I'm going to repeat myself one more time. Did you hear what I said? Isn't that what we tell our children when they're not following direction? If you have a cure, come in. If you don't, keep walking. And I said, wow. And, I said, I don't have a cure, but let me think about what you said and I'll come back and speak with you. I came back and speak to her at 5 o'clock that evening. And she's 18. At 16, her mom got off the bus, developed chest pain from work, got taken to a hospital and died of a heart attack. At 17, her sister was admitted to a hospital with sickle cell crisis and sepsis and died. She's now 18. She lives with her uncle. And from the way she described him, I'm just putting in very simple language, he didn't seem to be a touchy-feely type of guy. He seemed to be more food, clothing, and shelter type of guy. And she said another powerful statement. She said, you doctors don't teach me about sickle cell. Sickle cell teaches me. And so here is this supposedly disrespectful, attitudinal person who is very analytical, understands her conditions, and is very intellectually very capable of assessing circumstances. So I said to her, have anybody ever referred you to a therapist? She said, no. Have you ever had depression screening? She said, no. And she teared up and literally sort of hugged each other, And she said another powerful statement. She said, you doctors don't teach me about sickle cell. Sickle cell teaches me. So if you look at who this intellectual person is, as opposed to being disrespectful, that whole perception, and so was really her getting to know her and getting to understand. I designed a program to form the first sickle cell support group at Queens, and I collaborated with the head of the department the emergency department. So when a patient came in, there's a protocol that was developed. The care managers who was in the emergency room would contact that person, go and see that person. In addition to the physician and the physician assistant, whoever is assigned to that person, and the care manager would ask him or her, would you like to join the support group? And for the first, and I went and looked at the literature, looked at research. I spoke to sickle cell organizations, different hospitals across the nation back then, and there was no adult sickle cell support group. And when I asked, did anybody do depression screening on this population? And no, the answer was no. And so this is one of, like I said, one of these stop in your tracks moment that cause you to really zero in on the individual, not the patient, who is that individual, and create an environment that you understand, because the patient is not the sum total of that individual. It's a part of that individual. And we started, so we would, when patients would come to the emergency room, and they had to eliminate the word drug seeker, because the medical literature does not support. They're the least addicted, but the most vilified for patients who require pain management. And there's a statement from Dr. Zemsky, who was a hematologist, and it's another statement that is also part of my mindset. He said, difficult patients are not just born. Sometimes they're created through the medical system. Not only the system failed to cure, they may have done not so nice things to make matters worse. You know, and so when we formed the sickle cell support, we had about 15 people, and we had before at lunch, we provided lunch, and we had it an hour before hematology clinic. And when you heard some of those stories, oh my goodness, and I just say a patient said, I heard her say, I hate my mom. I said, oh my God, how do you hate your mom? Oh my God, you know, and as a mother then, you know, of adolescence, she says, oh, no, I don't hate her now. I know she loves me over the moon, but I never understood when I was younger why she would side with the doctors to keep me in so much pain. Why didn't they just let me die? Wow. I said, ouch, you know, and then I learned about the family involvement. And just the last story I'm going to say. So it's two children. One had sickle cell disease, one did not. The daughter had it, the son did not. The son was on a basketball team, and the team never made it anywhere except first round, you know, and then they were all knocked out. This particular time, they made it to the semifinals. And so the family was excited. They were planning to go. She developed sickle cell crisis at 1 a.m. in the morning, so the family went with her, and he had to go to the game by himself. Mm-hmm. You know, and so that's when I realized that counseling, and so we added a therapist to the team, because you know they need therapy. You know, it's because of the interaction, the dynamics, and what's sad in the healthcare system, they don't talk about family traumas in patients with sickle cell disease. You know, and how is that managed? You know, and so it was really humbling. And over the course of time, I speak with the emergency room director, and he said, all the contentiousness, all that stuff is gone. You know, they have an assigned physician assistant who sees that person, and that person would contact the primary care doctor and say, John Brown is in the emergency room, or the hematologist. You know, so there's a humanizing of these individuals. And it was really humbling. So when I go back and say, you know, that my passion is to, you know, just get rid of the stigma. This is just a disease. Patients with sickle, get rid of it. And the reason why they go to the emergency room, the literature, medical literature states, because they're undertreated at the first go round. Mm. It's been proven they're undertreated. So if you're undertreated and now, you know, you're a couple of hours that you have the pain because you didn't get the amount of medication that you needed. So now when you go into the emergency room, well, you were just at this hospital, you know, oh, so you're drug seeking. Okay.
I think everything you're talking about, you know, it's compounded by the fact that people of color historically have had gaps in care in the healthcare system. That's just true. And then when you compound that with specialized, you know, disease care, sickle cell, and if you don't understand that, or what I heard from you just now, and you've talked about this a number of different times, is the concept of the common thread. What's the common thread? Not only on the patient side, but on the clinical side. So that's the and this is a complete family, the human experience. And you mentioned that some solutions may be as simple as they are complex. Now, do you have the specific examples of simple solutions?
Absolutely. So I'm just want to just explain the common thread a bit. So once individuals came to our institution and they were given a diagnosis that they did not want. Who wants the diagnosis of cancer? But once accurately diagnosed, it's non-negotiable. Across all race, religion, ethnicity, country of origin, socioeconomic status. The billionaire can say, oh, I'll give you $1 million to take the cancer back. Oh, that's not enough, I'll give you $5 million. There is no, in terms of, giving back that disease is no different with a homeless person than a billionaire. It's non-negotiable. And maybe if we understand that, we could be more empathetic as opposed to judgmental. Because in life, we have choice. You don't like the school your kids go to, you could change it. You don't like your crappy job, you don't like your family members, you could move to another state. If you bought something for 30, 60, 90 days and contract, you could return it. But when it comes to accurately diagnosed disease, there's no one that can give it back. So now how you may deal with your disease and how I may deal with it may be different based on who we are, the individual, our culture, and so forth. And I think once you capture that and to recognize that the people, the clinical team that are hospitalized, the majority of patients, doctors or nurses taking care of patients never been laid in a hospital bed.
Yeah.
But the ones that did were women delivering life and patients are trying to prevent death. So these are some of the areas that we can collaborate on and to make it a more, empathetic and in the concept of do no harm, So that's what I just wanted to clear up. And you mentioned about simple solutions to health disparity. Absolutely. So you ever heard the word non-compliant?
I've heard of the word non-compliant, but what does that mean in action?
Okay. You ever heard? There's a nicer word now, non-adherent.
Non-adherent. I think it's the same.
Yeah. So what I see going on in healthcare now, we're changing the language and make it nicer. They don't talk, when it started, it was health disparity. Now it's health equity. Then now we started with non-compliance, so now we are non-adherent. What is missing between the non-compliant? Non-compliant means you didn't follow directions, you didn't take your medications, you didn't do what you were told to do from a medical sense. Example, 60-year-old African-American male, and that negativity is more related to, in the medical literature that's been proven for African-American. 60-year-old African-American male, recently diagnosed with congestive heart failure, returns 2 weeks later for heart failure decompensated due to non-compliance. So what does that mean? So you're just diagnosed with heart failure. So when you get admitted, you think anybody upstairs in the unit is going to care about you? Because, so you don't take care of yourself. 2 weeks you got heart failure, you don't follow directions. I have other things to do.
Right, yeah.
So when we brought the patient in, of course, anybody that was on the team, my interdisciplinary team, because I was in charge of the congestive heart failure readmission prevention program at Kings County when I moved from Elmhurst and Queens to Kings, as deputy executive director. And the team, if they didn't X, Y, they know I was going to bug out. So X, Y. So you don't know why I didn't take the medication, but you're going to refill the same medication I didn't take, but you don't know why.
Yeah, just repeat the same cycle of non-compliance, right?
Yeah, exactly. So then we asked the patient, it was a real case that I gave a 60-year African-American male, brought new onset congestive heart failure. So we said, why don't you take your medication? He said, I can't take the water pill. And I'm glad you're sitting down. He said, why can't you take the water pill? Because I drive the number 6 train.
You're learning more about it. Okay.
Yeah. So you can't drive the train because he can't say the train is delayed because the driver has to find a bathroom. So what he does, so we brought it in. So when is your shift? He said 11 p.m. to 11 a.m. What do you do when you go home? He said, I tend to do some chores, make breakfast, take some of my medications and take a nap. But depending on my shift, if it's going to be the shift, I don't take the water pill, because I just don't know how I'm going to handle that. So the cardiologist said, and we said, okay, so here is what you do. When you come home, it's probably a better time to take the water pill, even though it will wake you up in the day, but by the time you get to your shift, which is 11 p.m., you would have less of a need to go to the bathroom. But to the degree that you do, we'll give you a cubicle that you could use it within the private space where you, as a driver. And you know what the patient says? Well, that works. If I knew I had to choose between peeing and breathing, I would have chosen breathing.
Very true. Very true.
Yeah. So you could see how that individual could be labeled as non-compliant, and if that person were to come back a month later and passed and died, and you go to mortality report, it would have said due to non-compliance. But so I think when I say the human interaction, but you have to value me to find out, and you have to ask why. Why? Because in medical school, we are trained to ask, why the fever? Why the headache? Why the abdominal pain? Why? But when it comes to a patient, an individual not supposedly following directions, we don't seem to want to know why. And it's a better way of collaborating because, Grant, if the perception of me is negative and it's not the reality, then my health is going to go south. But if the perception and the reality is the same, be it good, bad, happy, or sad, there's an opportunity to collaborate and understand, and so when we asked why, we got answers that we could help that patient. There is another case.
Let me ask you this before you continue.
Sure.
That other case, because what I heard you say there is around the trust factor, that you trust your, whoever your attending physician is or your care team to be able to talk to them and let them know. Now, I know that's a very personal thing. Hey, I work and I got to go to the restroom. I'm not taking this pill, because it's causing me problems, and I'm not reporting it back to you because of it. First of all, I don't even know that you even do care about that, and I don't know the effect of me not taking that pill. Like, has that been completely explained? Like, hey, if you don't take this pill, this is this, and this. What are the implications of that? So they can like, well, hey, this is the problem. We got to work this out. Do you have those kind of discussions?
Yes, and it has to do with the human value. So another person from a different race who comes in and have the same circumstances, does that person get asked these questions? And if it doesn't work, do they say, bring the family and bring the wife in? Okay. I think, and it's improved in the medical records. And if you write non-compliance and now the nicer word, non-adherent in the medical record 3 times, that patient is under the help bus. Nobody wants to deal with them because you are the problem. You go find. And I'm sure you have heard another negative word, frequent flyers.
Yeah.
Frequent flyer. So I can't prove this, but as I spoke to, and it's because I spoke to over 1,000 patients, and I think when you have that negative, non-compliant written medical record 3 times and nobody wants to deal with you, we literally could have possible turn that non-compliant without asking why into quote frequent flyer, because nobody wants to deal with that individual. And it is a reason why with the congestive heart failure readmission prevention program, we were able to decrease readmission from 30% to 18.7 in 2 years. The population didn't change, the clinical care, the so-called social determinants of health. The same people that were in the 30% was the same people in the 18.7. It wasn't like a whole bunch of rich people came in and they were in the 18.7. What changed was the improved heightened human value, being non-judgmental and asking a simple question if something doesn't work. And what I also did was a lot of surveys for the perception reality. So you heard HCAP scores, everybody's into HCAP score, was it patients think about the care they received and would they recommend the hospital. But you don't hear a lot of surveys on, so what does the staff think about the population they serve? Because if it's negative, you could see how it may impact the HCAP score. So when I ask the patients, and when I do surveys, the same questions I ask the staff is the same questions I ask the patient. And interesting, this is where the learning curve. So we ask, why don't you take your medication? Why don't patients take their medication? And the overwhelming response was, for this population, this cohort of patients, cost. They can't afford it. Yeah, they can't afford it. And it sounds reasonable. And this is from the ED, the inpatient physicians. When we ask the patient, do you know not one patient mentioned cost?
Wow.
You know what they said? You know what the top answer was? Why don't you take your medication? We think we're taking too many medications.
Yeah.
Because the average heart failure patients with comorbid conditions are taking like 7 medications 3 times a day. Not one mentioned cost. So what I'm saying, if you're designing a system based on your perception, that has nothing to do with reality. You could see how we're gonna spin our wheels and it's gonna go around. And so once we heard that, we were able to bring the pharmacist. She was an amazing pharmacist to look to see whether or not she can cut down some of the medication, increase, like the question, does a 80-year-old person really need to be on anti-statin medication for for cholesterol? Can we combine the antihypertensive medications? And we were able to cut down the medication, take at least about 5 as opposed to 7.
This episode is brought to you by 5-Star BDM. 5-Star BDM is a professional consulting and advisory group keenly focused on business development services for small to mid-sized businesses and entrepreneurs. Although every business is unique, they often share challenges that can be addressed through smart branding. Services include process improvement and operations, digital strategy and transformation, business intelligence, digital marketing, and personal branding. Our 5-Star business and personal branding company has helped a number of professionals and organizations to optimize and grow. The result is more business, more opportunities, better reach, positive outcomes. Please visit www.5starbdm.com to learn more and view all the episodes of Follow the Brand. It's such a disconnect. Talk about a gap that you have to cross over. Like if you feel that the problem here is the cost of the medication, and then on the other side, the person that actually needs this medication is saying, hey, well, I got too many pills. And for example, my stepfather had, he had to go through a heart surgery, right? And I remember him coming home from the hospital and I asked him, like, well, how many medications are you taking? He said about 20. He said, 20. I mean, that's just a ridiculous amount of medication. Now, if I ask him, like, well, what's this for? He probably got to about 4 or 5, and then he's like, I don't know what the rest is. And so it becomes a mess. And then maybe he stops taking that one because he doesn't really know what it's for. Exactly. And then he ends up again, maybe in the hospital or something like that. But you're saying that communicate, you have to have that communication constantly and advise people what's really going on.
Yes. And the question is one of the questions, again, perception, reality. What percentage of the patients do you think are insured? And the proverbial answer was 25 to 30%. What percent of the patients you think go to shelters? The proverbial 25 to 30%. What if I told you that 75% of the patients are insured and 3 to 5% of the patients go to shelter? Would that change the way you perceive the population? Because heart failure is for the elderly. With patients who are between 60 and 90, the bulk of the patients had Medicare. or they were retired union employees, had union plans, or they were on straight Medicaid. 75% were insured, 25% were not. But when you think about it, because of the age range, you know, but again, it's the perception reality. And what we were able to track down was to solve the perception reality. And one of the things that came up, particularly with the elderly Black population, which nobody speaks about, the role of religion in this population was pivotal. And so when, you know, and a patient said, you know, it's in God's, no, before that story, the patient said, this is on a Wednesday. All I want is to be able to go to church on Sunday. This was a Wednesday.
Yeah.
She stopped eating. She stopped, you know, participating, and they're blaming her for she doesn't care about her health. And I said, she's depressed, and you have to get depression screening. Everybody said, yes, call the site, get depression screening. Absolutely. But the other thing you need to do, find out what church she goes to, find out who the minister is, and let me call the church, the minister. The minister came in and prayed with her and told her, even if you're not discharged on Sunday, I will come back and pray with you. It was a different individual because she wanted to please God. Mm-hmm. And so, yes, so there is the clinical piece, but part of the cultural piece is the role of religion. And I think if we didn't call the minister and had him come in, depression screening would have said she's depressed, but she wouldn't have changed it. She stopped eating, she stopped participating. She was just totally, because she said, all I want, what I'm most concerned about, that I won't be going to church on Sunday. So when somebody tells you that information, don't judge.
Yeah, and what I heard from you just now, I mean, for this half hour or so that we've been talking, that it's training on the clinical care team to go that extra mile, to look at how your workflow is structured and how can we change that? Because you said the perception is reality. Where does that perception come from? Where's that data of perception coming from? And have you designed the program, the care delivery to get better outcomes by better communication?
Yeah, I think and again, if the perception, sometimes people they think perception is reality. So there's no need to do data analysis, because what do we do? This is what we're going to find. But the good news is that once we change the dynamics and show the reality of the data, that 75% of the patients were insured. And the question was, if you know that, would you treat the patient any different? And it's not to say because people are insured, they should treat any different. Yeah. But if you think in that negative frame, so he has no insurance, he's not going to be able to afford his medication. You know what I mean? So you have this whole thing that had nothing to do with reality, but it was not just at that hospital.
That's a misdiagnosis. That's what.
Yes, it's in a lot of health systems. It's in a lot of health systems. Yeah. And it was humbling because when you hear the history, and from a cultural perspective, when a patient says, I picked cotton in the South and I paid my dues, I don't deserve to be treated this way. Who understands that correlation with the cultural? And I think that it's so important. That's why I said cultural competence has to be, not as a nicer word, cultural humility. I'm not into I don't know if I like the word humility. I'll go with cultural sensitivity a little bit better, But I think it's important to realize that cultural competence has to be bidirectional. American-born physicians to foreign-born patients, absolutely. But also foreign-born physicians to American-born patients, and American-born physicians to American-born patients who are different than themselves. Because currently, Grant, the English-speaking population is left out of the cultural competence conversation. Mm-hmm. So who are you leaving out?
Yes, very important. And what you just described over and over again, that when you don't have the communication and becomes a gap and you're living in your own perceptions, but that is not what's really happening. I think that's important. So tell us about your business, because you're doing things right now from a training perspective to help organizations to have these kinds of conversations.
Right. So I created my own company, Mauvareen Beverly, MD, PLLC, Patient Engagement and Cultural Competence. And I've done training at different institutions, different organizations, and collaborated with other entities to combine technology with patient engagement, because everybody's talking about telehealth and, but how do you engage the person who have signed up for whatever it is they signed up for? And then if in 2 weeks later, they say, no, I don't want it. And it has a lot to do with the patient engagement portion of it. And as a learning curve for me as well. But that's what I realized. And so when I educate people and speak to I say, let me hear the conversation. So let's say, for instance, an elderly person is discharged at home, needs scale, needs blood pressure machine and so forth. But if you don't know that individual and you don't know whether that person lives alone as opposed to living with family, it may make a difference, and so there's a way of communication. And the other thing that the literature now is showing is that telehealth for some of the Black patients don't particularly like telehealth, but I think it's fixable. And they didn't say because people didn't have the Wi-Fi, they didn't have, the tools. I haven't heard that. But one of the things that I mention when I do presentations and training is when I come to you face to face in your office and you're not communicative with me, so do you think that person is going to be communicative with me in a virtual setting? And I think this is where something, I would want to look into further, because if so I'm in your office and you're not communicative, and so now I'm going to go on telehealth, is that going to change the dynamic for the better, or is it going to get worse? So it's something to think about.
Now, the empathy is real, and taking the necessary proactive step to actually talk about the experience with the patient. What is your experience? What's going on? Just everything that's going on with you. And can we talk about that? At least listen. Maybe you can't make a lot of change, but if you learn something, what I heard from your discussion tonight, you learn some things that then all of a sudden like, aha, you know what? I can't do that, because you couldn't solve sickle cell. Like, no, I can't. I don't have a cure for that. But you were able to help her in a number of other ways. And she helped you as well.
Oh, absolutely. Absolutely. And I think what we realize from my perspective, patients with sickle cell, there is the unimaginable physical pain when someone is in crisis and the blood flow to organs is just not available. But then there is the emotional and mental pain of being called a drug seeker. And one of the physical pain, is part of the disease, but the emotional and mental pain of being called a drug seeker should not be. That person should not encounter two types of pain. One is not necessary, and it should not be a part when somebody's in this excruciating pain. And I think there needs to be a national policy to get rid of the word drug seeker, because it's not supported by the medical literature. They are the least addicted for people who require pain management, but the most vilified. And why is that? And when they graduate high school, and they go into college, we should celebrate. Get midway, celebrate.
Yeah.
And bring in the health plan, because if now you're in New York, but you're going upstate, maybe to Buffalo to school, or you're going to South Carolina, wherever you go in Boston, does your health plan cover you out of state? And this is something that we were planning on having a celebration and bringing in the health plans to go over to explain, because at that age, when my kids were that age, nobody knew anything about health insurance.
Yeah.
You know,
Right.
we still don't know anything enough about health insurance, but it just tells you that. And one of the statement from the patient was, do they treat us this way because of who we are? I have dreams and aspirations like anybody else. And I said, absolutely, absolutely.
Those health equity and all those, the buzzwords don't change anything.
No,
The realities are the realities. We have to hit them head on. And I applaud what you are doing, because you're bringing a conversation that we don't necessarily have from the clinical side of things and understanding. And they've got, everybody knows right now with the labor shortages, the ability, there's just shorter time span to even spend with patients. And these are big things. So any kind of help that you can give from a training perspective and make the interactions that you do have with a patient effective. You've got 5, 10, 15 minutes, make them as best as possible.
Right. But what's interesting? So if you decrease the readmission, less people coming in, that's going to be, quote, viewed, and the nurse get upset or the doctor get upset. So you readmitted for not following. But if you decrease that, it changes the dynamics. It really did,
Yeah.
And what I found, which, and again, is one of those stop in your tracks moment. I remember on the team, one of the nurses came over. She was not a part of the team, but she said, that patient over there is non-compliant. And the nurse said on the team, no, go ask him why. Go ask him why. So it was the each one teach one.
Right.
So it didn't come from me. It didn't come from the top. It came from, their other, co-workers. And I remember she said, no, go ask him why. Go ask him, find out why.
Well, I tell you, I know what the audience wants to ask you a lot of the questions. You brought up good things like lowering readmissions is huge with your program. So what is the best way for the audience to get in touch with you?
Okay, yes, they could, my email address, you could put it in the chat, I guess. It's mbeverlymd@gmail.com. And that would be the easiest way. And
you have a website as well.
I have a website. I was going to say I have a website as well at drbeverly.com. And so that would be a great source as well. And I just want to let you know, I'm going to be a part of a panel in Chicago on health disparity, at the, so I'm very excited about that, to be able to be in a discussion. And it's going to be a lot of different Rush Medical Center and Aurora and, Chicago University, and what I'm learning in Chicago, there's a lot of hospitals, like New York. And, so the concepts, I think, is being looked at, as you say, it's a different way of approaching.
Yeah.
This very highly, this highly controversial topic.
And that's fine. We're going to go ahead and conclude this conversation. I'm going to encourage the audience, even if they cannot attend in person.
Right.
A lot of times there's backup notes on the conference and what's going on. It might be recorded, so there might be a virtual video of the conference, and I think that will be wonderful. You have given us a lot of food for thought. I encourage all of our audience, especially our hospital executives, to examine some of the things that you brought up and look at their teams and see how that can be very, very impactful. You do have a training program that they can engage with you on.
Absolutely. As a consultant, that's what I do. And I just presented in April in Social Work Month at Northwell.
Awesome.
And so it's multidisciplinary. And it really, and like I said, one of the end of the survey, one of the questions that I focus on, after hearing the presentation, would it change the way you react to patients? And over 90+% always said, yes, they would.
I can see the hands going up already. My hands are already going up because you changed my perception on a lot of things. So this has been wonderful. I'm going to encourage the entire audience to listen to all the different episodes on the Follow the Brand. You can tune in at www.5starbdm, that's B for brand, D for development, infomasters.com. And I want to thank you very much for Dr. Beverly for being a guest on the show.
Oh, thank you for the invitation. It was great. And looking forward to continued collaboration with you.
Absolutely. Take care.
You too. Have a great evening and stay safe.
I will.